alveolus, where it can then exit. As you can tell, these gases have very different properties. Oxygen is incredibly soluble carbon dioxide is very soluble in the blood and is limited in its transport out of the alveolus only by a patient's minute ventilation. In contrast, oxygen has... ¡Con los terroristas! The purpose of the hypoxia drill is to identify acute reversible causes for a drop in saturation for a patient on the ventilator. And the easiest way to think about this drill is to run from the wall to the patient and the patient back to the wall. Let's take a moment to go through those steps. The first step is to increase the FiO2 on the ventilator to 100%. Next, you should remove the patient from the ventilator to eliminate the ventilator as a possible cause for the desaturation, and you should bag the patient with an ambu bag. If the patient is on a substantial amount of PEEP, you should add a PEEP valve while bagging the patient. Step 3 is to assess the patient themselves, and I do this by walking down the endotracheal tube all the way out to the lungs and then looking at the patient broadly and going back to the wall. So first I look at the teeth, then I assess the trachea for any deviation, and I look for chest rise while I'm bagging the patient. Then I listen for breath sounds to see if there's asymmetry. There won't always be if there's a problem with the endotracheal tube or even a small pneumothorax, but a marked difference would cause me to work up other causes. Finally, you should feel for any resistance in the system while you bag the patient, and you should actually place your hand on the chest to feel for a chest rise. The final step in the hypoxia drill is to walk from the patient back to the wall. Does this patient have a chest tube, for example, which may have migrated or come out during transport? Is there a central line, which also may have been removed? Perhaps the patient had some sort of air embolus, etc. Now let's show you how the hypoxia drill works. And for this, we'll turn to Dr. Nancy Knudsen.
Hi, Mr. Davis. I hear your alarm's going off. Ooh, I don't know what happened while I was in lunch. Let me see if I can get us some help. Dr. Knudsen, can you come give us a hand, please?
Sure. What's going on, Gene?
I just came back in from lunch and noticed that his alarms are going off. His saturations appear to be low.
Great. I'll tell you what, why don't you get respiratory in here. First, I'm going to turn him up to 100% oxygen on the ventilator. Hey, Mr. Davis, it's Dr. Knudsen. You doing okay? Gene, he's not as awake as he was before. I'm going to go ahead and start bagging him with 100% while we wait for respiratory. Let me just get it turned up here. Take him off the ventilator. You know, his compliance feels good. Hey, Allison. Mr. Davis's sats went down while Gene was at lunch. His compliance feels good, but I'm not quite sure what's going on. Will you bag him while I go take a quick look and listen? Thanks. All right, so looking at him, I see symmetric chest rise. Feel symmetric chest rise. Trachea is midline. There's no shift. Let me take a quick listen. Sats have come up a little bit with you bagging. They're up to about 88, but they were at 100 earlier when I was examining him. You know, he sounds nice and clear. I don't hear any problem there at all. Let's go ahead and take a look. I do not see him biting the tube at all. Can you give me a suction catheter? Let's make sure it passes easily, that there's not a mucus plug. I do notice that the endotracheal tube looks like it's moved. It's in at about 26 centimeters at the teeth, and it had been at 22.
Yeah.
Just very minimal scant secretions. Why don't you keep bagging? I'm going to go ahead and move that endotracheal tube back here. Okay. All right. Mr. Davis, you're going to feel a little tape pulling loose here. Just hold ventilation if you can while I let this cuff down. Okay, you can resume. I'm going to reconfirm breath sounds with moving the endotracheal tube. Sats are up to about 94, 95. Good breath sounds. Want to just make sure with manipulation of the tube that we still have end tidal. Okay, go ahead. Good purple to yellow color change. Sats really only came up to about 94. You know, he's on all that PEEP on the ventilator. I think maybe just going the right main stem caused a problem. Why don't we get a PEEP valve for me? And then let's plan to do a recruitment maneuver on the ventilator, okay?
Yeah, let me grab a PEEP valve.
Great, thanks so much. Okay, I'm going to turn him up to 10 a PEEP, which is what he was on the ventilator, and see if we can't re-recruit these lungs. You know, I'm so glad. I wish one of the medical students was here. You know, they often think that you can't be just ventilating one side and have bilateral breath sounds, but they can be transmitted.
Yeah.
All right, let's hook him up and do that recruitment maneuver.
Okay.
Okay, 30 centimeters of water for 30 seconds, please.
Got his vital signs?
I'm watching his vitals to make sure there's no changes.
All right, starting the recruitment maneuver.
Great, vitals are stable, sats are 100. Good, equal chest rise. I think the only thing left to do is check a chest x-ray and make sure our tube placement's okay. Jean, can you call radiology for me?
Okay, recruitment maneuver's done.
Great. We're going to go back on your normal ventilator settings. Hey, Mr. Davis, looks like you're a little more awake. Dr. Knudsen here. Your tube, endotracheal tube, had shifted a little bit, but I think it's in the right position. We're going to get a chest x-ray just to confirm, sir.
I'll have the resonant put in order.
Great. Thanks so much.
Let's take a few
All right,
moments
sir. I'll
to
be back
review
to
the
check on you in a
hypoxia
little
drill that
bit.
you just saw in a little bit. An occluded endotracheal tube can be diagnosed when you cannot pass the suction catheter. An appropriate treatment will be bronching the patient with suction. Sometimes you need to instill saline. And sometimes if you can't get the secretions removed, you actually have to replace the endotracheal tube. An endotracheal tube which is migrated is usually diagnosed by asymmetric chest rise as well as asymmetric breath sounds. Sometimes a history suggests that this may be possible. The patient may have recently been transported, or they may have been turned for a bath, etc. You can diagnose this by performing a bedside bronchoscopy and looking for where the end of the endotracheal tube is. If you have time, you can perform a chest x-ray. And if you don't, you can just pull back the endotracheal tube. Make sure after pulling back the endotracheal tube that you confirm its placement with end-tidal CO2 and by listening to the patient. Differentiating a mucus plug and tension pneumothorax is important in clinical practice. When a mucus plug is present, the trachea will be deviated to the side of the mucus plug. There will be breath sounds absent on the side of the mucus plug. So if you have a mucus plug in the right side, the trachea will be deviated to the right side because of volume loss in the right lung. You treat this with suctioning, and sometimes this requires bronchoscopy. A tension pneumothorax is different, however. The increased air pushes the trachea to the opposite side of the pneumothorax, so breath sounds may be diminished on the right side and the trachea is deviated to the left. Usually, when there's enough air within the chest to cause the trachea to be deviated, there will be hemodynamic instability. The management of a tension pneumothorax is immediate needle decompression in the second intercostal space in the midclavicular line, followed immediately by chest tube placement. Let's take a moment to review the differential for abnormal breath sounds. When crackles are present, it's usually indicative of adult respiratory distress syndrome, also called non-cardiogenic pulmonary edema, or cardiogenic pulmonary edema, or CHF. Treatment is usually application of PEEP, diuretics, and to consider what might be causing this. If this is acute congestive heart failure, rule out a new myocardial infarction or the presence of a flail mitral valve. Pneumonia usually presents with focal findings, which can be tubular breath sounds or crackles. Patients should receive antibiotics, and you should consider a bronchoscopy if the patient is intubated to obtain cultures. A hemothorax and pneumothorax may present with decreased breath sounds on one side with possible deviation of the trachea on the other, and is treated with a chest tube. If there's hemodynamic instability, the chest tube should be preceded by a needle decompression. Bronchospasm can cause a wide differential. Usually there's diffuse wheezing, and there may be a history to suggest why the patient is wheezing, for example, a history of asthma. The patient may have recently had a drug administered to which they have an allergy, or they might be having a transfusion reaction. Treat bronchospasm with bronchodilators, and if the patient may be experiencing an allergic reaction, give epinephrine. A foreign body presents with a focal wheeze. and may have a history of possible aspiration. For example, the patient may have aspirated and has a chunk of meat in one of their airways. Children often aspirate things like peanuts or foreign bodies from the outside. If the patient has a recent intubation and a focal wheeze, it's possible that a tooth was knocked off. Foreign body must be treated with bronchoscopy to retrieve the foreign body. Let's take a moment to review proper chest tube functioning. When a chest tube is placed to suction, you want to look at the area on the pleurovac indicated by the yellow square. Suction is applied by turning a dial. So you can see on the left has 20 centimeters of water pressure applied of suction. When suction is present, it will suck up a small piece of plastic indicating that the pleurovac is functioning properly. When suction is properly there should be a red piece of plastic, as indicated by the second yellow rectangle.
Do the Harlem Shake.